So welcome to the lecture of endocrine emergencies. So as part of your EDIC 2 exams, you will be getting long case, you will be getting your short cases. So you could get a case on endocrine emergencies, or it could be part of your other case discussions also. You might get some questions on endocrine emergencies. So it is not certain emergencies are very commonly seen in the critical care unit. Some are not very common, but they can be very life threatening. So we need to be aware of how to diagnose them, how to treat them, because many times the presentation is in a very life threatening way. Okay, so we'll start with the presentation now. So these are the common endocrine emergencies that you could come across in the ICU setting, involving different systems. So we'll go through them one by one. So this is a case presentation that we'll be discussing. So there is
Very
a,
good evening, ma'am.
yeah, tell me.
Yeah, ma'am. Yes. Okay. Yes, ma'am. So we can start the class. Yeah.
Yeah. So going back to the first case, so there is this 55 years old lady who is a known case of diabetes, blood pressure on treatment with dapagliflozin, who has presented with abdominal pain, fever, vomiting, and altered sensorium. So in your exams, you will be given a case like this, and you will be given a case scenario, you'll be given some set of investigations. So you will have to interpret, and according to the questions that they will ask, you will have to answer. Your answers have to be to the point and very focused. Okay, so for example, in this case, so there is this patient who's presented with abdominal pain, fever, vomiting, altered sensorium, drowsy but responding to pain. The heart rate is 120, blood pressure is low, saturation is okay, 93% at room air. She's tachypnic, respiratory rate is high. Per abdominal examination is soft, there is mild tenderness, doesn't look like an acute abdomen. She is dehydrated, there is poor skin turgor. So you do a CT scan because she's presented with drowsiness, that is normal. You do an ultrasound abdomen because of the pain abdomen, acute presentation. There's only fatty liver, no other signs of any acute abdomen. Investigation, lab investigation, hemoglobin is 14, WBC counts are high, 30,000, normal platelets. The random blood sugar is 500, very high. The BUN is 70, creat is 2.3, electrolytes, hyponatremia, hyperkalemia. Your ABG, as you can see, is showing a metabolic acidosis. Anion gap is 22. So this is a high anion gap metabolic acidosis. Lactates are relatively okay. They are 3.3, not very high. And your urine ketones are 3 plus. So you'll be given a case scenario like this. Now you have to come up with a possible differential diagnosis. Okay, so I think you can all agree that one differential diagnosis is diabetic ketoacidosis. So diabetic ketoacidosis, what is it? It's a life-threatening complication actually, mostly seen with type 1 diabetes, but it can present in type 2 as well. So it is a triad of hyperglycemia, ketonemia, and a high anion gap metabolic acidosis. Similar to that, there is a state known as hyperosmolar hyperglycemia state, which has got moderate to variable degree of clinical ketosis, which you can detect, and an altered consciousness with or without coma. So we'll see one by one how these things are differing from each other. So diabetic ketoacidosis means the triad is there. There is hyperglycemia, there is ketosis, as well as metabolic acidosis. Each one of them can be having different causes. But when all three situations coexist, then you know that you have diabetic ketoacidosis. There are other causes of metabolic acidosis also, with normal anion gap, high anion gap. Okay. So how does this happen? Why does this happen? Why do some patients develop DKA? Why do some patients present with HHS? So what happens is, as you know, there is in diabetes, there is an insulin deficiency. So whenever there is the state of absolute or relative insulin deficiency, the counter regulatory hormones go up. So what happens in absolute insulin deficiency is, because of the lipolysis, there is more free fatty acid getting delivered to the liver, which gets oxidized in the liver and ketone bodies are formed. So there is ketosis, there is ketoacidosis. And when the counter regulatory hormones go up, the protein synthesis reduces, proteolysis increases. There are more gluconeogenic substrates. So insulin is normally supposed to increase glucose uptake in skeletal muscle, decrease the gluconeogenesis, decrease the glucolysis. But when the insulin is deficient and the counter regulatory hormones increase, so all these gets disrupted and there is hyperglycemia. So what your hyperglycemia does is it causes glycosuria, there is an osmotic diuresis, there is loss of water, electrolytes. This is why these patients are very severely dehydrated, hyperosmolar. There is GFR goes down, there is an impaired renal function as well. Okay, and why some patients get HHS is because the insulin deficiency is relative. So the acidosis does not happen to that extent. Hyperglycemia and hyperosmolarity are the main presenting features. So this is how your ketoacidosis and HHS differs in the pathophysiology. So there is always a precipitating factor when a patient with type 2 diabetes presents with this. So in addition to investigating for the metabolic abnormalities associated with DKA, it is very important to know what has precipitated this. So the common precipitating factors, either there is a some infection, some other metabolic stress, or in specifically this particular case which we discussed, this patient is on a drug known as dapagliflozin, which is an SGLT2 inhibitor. So this has induced a DKA. So this drug basically, which is used more and more in the treatment of diabetes, and it is also useful in the the heart failure patients. So what happens in this is it basically it is expressed in these receptors are expressed in the pancreatic alpha cells, and they are responsible for glucagon secretion and for decreasing the ketone excretion in the body. So any other precipitating factor can cause a decay in the patients who are on these drugs. So any intravascular volume depletion with diarrhea, any ketosis prone state like reduced oral intake, any infection, any alcohol ingestion can precipitate a DKA. So this patient, the precipitating factor is the presence of this drug. Clinically, how do these patients present? So they present with symptoms of hyperglycemia and they present with symptoms of volume depletion. Plus, there are symptoms of the probably the precipitating factor which exists. So there is polyuria, polyphagia. This is because of the glycosuria. Volume depletion causes thirst. There is polydipsia. There is an acute abdomen-like state with vomiting and abdominal pain because of the ketogenesis. So signs of dehydration, shock, Kussmaul's respiration, hypothermia. The presenting feature is altered sensorium. There is varying degree of altered sensorium which happens because of the hyperosmolarity. Severe cases may come with coma. There may be some focal deficit, seizures, which happen. Seizures happen mainly because of the hyperosmolarity as well as the electrolyte imbalances. Cerebral edema is responsible for the headache and the confusion. So the electrolyte abnormality which we see is hyponatremia. Hyponatremia happens because it is a pseudo hypernatremia because of the hyperglycemia. So when we calculate the corrected sodium, we have to add 1.6 to every 100 milligram deciliter increase in the glucose above 100. So if it is 2, if the blood glucose is 200, we add 1.6. If it is 300, we add 1.6 plus 1.6. So that is how we correct the sodium. So the actual sodium is higher. What it presents with is pseudo hyponatremia. There is hyperkalemia. So hyperkalemia happens because the potassium utilization is less. The potassium shifts happen because of the dehydration and everything. The total body potassium is actually low. These patients are intracellularly potassium depleted, but the presentation will be with a hyperkalemia. Hypophosphatemia will be there despite the blood phosphate levels being near normal or maybe a little on the higher side. Leukocytosis, hypertriglyceridemia, hyperamylasemia occurs because of the carbohydrate metabolism abnormalities. So what is the severity and how do we distinguish this DKA from HHS? So as your case progresses, these are the kind of questions that you will be asked pertaining to the case. So this patient, as you know, has presented with metabolic acidosis, if you remember the case scenario earlier. So we can actually classify DKA mild, moderate, and severe depending on how severe is the acidosis and the anion and the urine ketone, also on the clinical features. So arterial pH of less than 7 would be severe with a bicarb of less than 10, positive urine ketones, serum ketones, and osmolarity, higher osmolarity, and an anion gap of more than 12, and stupor and coma obviously being the more severe presentation. HHS will have a higher plasma glucose, more than 600, but the acidosis will not be that severe. The pH will be more than around 7.3. The urine ketones will be maybe mild, not very high, but the osmolarity will be very high. Serum osmolarity may be more than 320 also. Anion gap will not be high, and the neurologically the coma stupor state might be more than you see in your diabetic ketoacidosis. This is clinically how you will distinguish between the two conditions. So coming to the management, now how do you manage this situation? So this patient was started on an infusion of insulin and vasopressor support because presented with hypotension. So she was given a fluid bolus, 500 ml, normal saline. And because of the acidosis, she was given a 200 ml of soda bicarb bolus as well. But after 2 hours of starting therapy, the hypotension worsened. The acidosis was worsening and there was very severe hypokalemia happening. So what did they do wrong? Why this hypotension? Why is the clinical condition worsening? So the treatment of diabetic ketoacidosis consists of three primary parts. One is your fluid resuscitation, second is your insulin therapy, and third is the correction of electrolytes. So you're supposed to start your therapy with fluids because there is severe dehydration. The fluid deficit will be around 10 to 15% of body weight, and immediately giving fluid bolus, correcting the hypovolemia will improve the perfusion. It will clear the ketones faster. It will also improve the glycemic control. So the first part is to give IV fluids. So how much IV fluids we should give? You start with isotonic fluids. You can start with normal saline. You have to give 15 to 20 ml per kg body weight in 1 hour. Subsequently, you can switch over to half strength NS, and you have to keep correcting your fluids depending on the hemodynamics, depending on the urine output, the sugars, everything. So you can subsequently correct at 250 or 500 ml per hour. And once the sugars come down to 150 to 250, at that point you switch over to your dextrose containing fluids. Now insulin, you're supposed to start with a bolus of 0.1 unit per kg per 0.1 unit per kg body weight bolus. Then you continue with 0.1 unit per kg per hour. The rate of drop of blood sugar hourly you need to monitor, and the rate of drop should be 0.14 unit per kg per hour. Okay, so you start your patient first, you correct the give boluses of fluid, correct the dehydration, then start your insulin infusion, and then coming to your potassium correction. So like I told you, these patients are going to be intracellularly potassium depleted, but the serum potassium will be slightly on the higher side. So you need to start correcting your potassium with your IV fluids as soon as the potassium starts going below 3.5 or so. So you start your boluses. Till then, you add your potassium correction 20 to 30 MEQ per liter. You start adding to the IV fluids. Any patient who presents with the potash hypokalemia is already having very severe uh, hypokalemia. So in these patients, you have to correct your potassium before you start in them on an insulin infusion. Because the moment you start an insulin infusion, the potassium is again going to shift, and you will get very severe hypokalemia and possible arrhythmias with that. Soda bicarb, we are supposed to give only if there is severe acidosis. If the pH is less than 6.9, then you can initially give some ampules of soda bicarb. But subsequently, as the dehydration is corrected, as the blood sugars come down, the acidosis will get corrected and the anion gap will start closing down. So there is a rate at which the blood sugar should come down, and the rate at which your insulin infusion should be titrated. If the rate is more than 2 units per hour, you decrease your insulin infusion by 50% and try to maintain your sugars as near normal as possible. You continue your dextrose containing fluids if the sugar is between 150 to 250. So HHS, how does the therapy of HHS differ from diabetic ketoacidosis? Is the acidosis is not that severe. You need to give your fluid correction. You need to switch over once the to half strength NS if your serum sodium is more than 140 and your hemodynamics become more stable. And potassium correction, the principle remains the same. Insulin also you need to correct at the same rate. Decrease your insulin infusion rate to less than 2.025 unit per kg per hour once your blood glucose goes below 250. So this patient's condition improved. The bicarbonate levels increased to 16. The pH went above 7.3 and the sensorium improved. She was started on an oral diet. The insulin infusion was stopped and changed to bolus subcu doses. So how do we know that the acidosis is now resolving? So signs of resolution are, one thing is when the sugar goes down to less than 200, the bicarb increases to more than 15, the pH is corrected to more than 7.3, and the anion gap closes down to less than 12. So at this point, we can switch over the patient to subcut insulin. Complications that can be expected, one is hypoglycemia can occur because we are correcting at a very rapid rate. Hypokalemia needs to be monitored very carefully and corrected. Cerebral edema can occur because of the hyperosmolarity. There can be a non-cardiogenic pulmonary edema or DIC.